Block 1, Unit 2, Current Approaches to Treating Cancer. Surgical oncology is the use of surgery to treat cancer. Surgery is done to remove tumors that are cancer. Surgery can be used by itself to treat the cancer, or it can be done with other treatments. Not all cancers can be treated with surgery. In the case of blood cancers like leukemia, there is no mass to remove with surgery. In some cases, the patient may not be healthy enough to have surgery. For others, the tumor may not be able to be safely removed without causing problems for the patient. The cancer treatment team will help decide if surgery is right for the patient. Surgery in cancer care is used to 1. Diagnose and stage the cancer, 2. Remove the whole cancer, tumor, or mass, or 3. Remove some but not all of the tumor. A surgeon may not be able to safely remove all of the cancer because it could harm other parts of the body. This is often called a debulking surgery. 4. Ease the symptoms caused by cancer. This is called palliative surgery. Or 5. To return or change the body's condition after a surgery. This is called reconstructive or restorative surgery. Examples of this type of surgery are breast reconstruction or reversal of colostomy. How is surgery used with other treatments? Surgery may be the only treatment for some patients, but for many people, surgery is also used with other treatments. These can be chemotherapy, biologic, targeted, or immune therapies, radiation therapy, or hormone therapy. Other surgeries, such as those used in interventional specialties, may be used too. Surgery may also be called a neoadjuvant. This means the surgery is done after some other treatment. In some cases, more treatment will be given after the surgery. An adjuvant. This means that the surgery is done before the other treatments. What is chemotherapy? Chemotherapy is a type of medicine that's used to treat cancers. And how does it work? Tumor cells, which make up cancer, grow and reproduce very quickly in a relatively uncontrolled manner. Normal, healthy cells know to stop reproducing and growing when they touch other cells. Cancer cells do not and keep on growing. RNA and DNA in the cell can tell it how to grow and reproduce. Chemotherapy damages the RNA or DNA, which stops the cancers from growing. To do this, they often exploit the cell cycle. What is the cell cycle? The cell cycle describes the way a cell copies itself to make more cells. This happens in phases. A resting phase, or G0, where nothing is happening. G1 phase, which is gap 1, a growth phase. S phase, a synthesis phase, when the copying of DNA occurs. G2 phase, or gap 2, where more growth occurs. And M phase, mitosis, which is the division from one cell into two. How does chemotherapy affect the cell cycle? Some chemotherapy and medications can kill a cell during any phase of the cell cycle. They're called cell cycle non-specific agents. Other chemotherapy medicines kill cancer cells only during a certain phase. They are also not able to work in the resting phase. These are called cell cycle specific. Cell cycle non-specific chemotherapy facts. These kill cancer cells at all phases of the cell cycle, including the resting phase. These medications work best when given in a bolus dose. A bolus dose is a large dose given over a short period of time, usually intravenously. For example, the dose may be given once over 20 minutes. The cells don't necessarily die right away. A cell may have to go through several cycles before it dies. Repeat doses of chemotherapy may be given to continue to kill cancer cells. Cell cycle specific chemotherapy facts. These medications are often given more than one time. This gives the chemotherapy the best chance to kill as many cells as possible. Multiple doses are necessary because all cells are not in the same phase of the cell cycle at any given time, so all cells aren't susceptible to the drug at the same time. They may be given in divided doses or given multiple doses. For example, once a day for 5 days, or every 3 hours for 4 doses. They can also be given as a non-stop infusion. This is an infusion that runs for several hours or more. Some chemotherapy infusions are given over several days, and in both cases, the route of administration is intravenous. How is a chemotherapy given? Chemotherapy is called a systemic therapy. This means it travels throughout the entire body to kill cells. Surgery and radiation are called local therapies because they treat only a certain part of the body. Chemotherapy can be given to a patient in a number of ways: orally, by mouth and pill form, intravenously or IV through a vein, either as a short infusion or continuously for 1 or more days, or as an injection in through a needle, directly into a body cavity, such as the bladder or abdominal cavity, and intra-arterially, or into an artery, which is used in special cases such as limb perfusion treatments for melanoma. When is chemotherapy given? The treatment may include more than one type of therapy: surgery, radiation, chemotherapy, etc. Some common terms used to describe chemotherapy treatments are adjuvant therapy. This is a chemotherapy given after surgery to reduce the chances of a cancer coming back. Neoadjuvant therapy. This is a chemotherapy that's given before surgery to shrink the tumor. This is to allow the surgery to be more successful. Or 3, a concurrent therapy, when 2 or more therapies like radiation and chemotherapy are given together. What is a regimen? The regimen describes the combination of chemotherapies patients may get. A combination is given because different chemotherapies can work well together. Regimens can be given nicknames based on the chemotherapies used in them. For example, the regimen called CHOP contains the medications cytazan hydroxydaunorubicin, also called adriamycin, oncovin, and prednisone. What is a cycle? A cycle is a block of time in which a regimen is given. Each regimen can have a different cycle time. A cycle of CHOP, for example, usually lasts 21 days. This is how the cycle breaks down. Cytazan, C, hydroxydaunorubicin, H, and oncovin, O, are given on day 1. Prednisone, P, is given on days 1 through 5. The patient then has 16 days off without chemotherapy. This totals 21 days, making the cycle complete. The patient then starts all over again for a new cycle. The regimen and cycle will depend on the type of cancer and the treatment plan. What is the goal of treatment with chemotherapy? The goal of chemotherapy treatment depends on many issues. These can include what type of cancer the patient has, where it is, and any other medical problems the patient has. Although rare, chemotherapy may be curative. A few cancers, including Wilms tumor, a rare kidney cancer, acute lymphocytic leukemia, ALL or blood cancer, Burkitt's lymphoma, and non-Hodgkin's lymphoma, can sometimes be eliminated through aggressive use of chemotherapies. A second goal of chemotherapy is to control the cancer. This aims to prolong remission, or the amount of time in which a patient is cancer-free, and to decrease the rate of relapse. Finally, chemotherapy may be administered to increase the comfort of the patient, palliative care. This is not considered a treatment per se because it aims to simply reduce symptoms in the final stages of life. What is radiation therapy? Because you will have the opportunity to irradiate your cancer model in the Discovery Lab, we place special emphasis on this mode of treatment. Radiation therapy uses high-energy X-rays, also known as gamma radiation, to kill the DNA of cells. This kills the cancer cells or stops them from reproducing, and can also damage or kill healthy cells in the area of the tumor. It is used to treat many types of cancer. It is estimated that 50% of cancer patients will receive radiation during treatment for their cancer. Radiation therapy is called a localized treatment. This is because it treats specific areas of the body where the cancer is growing. That is different than a chemotherapy, which is a systemic therapy because it can travel to all areas of the body. There are 2 types of radiation therapy: external radiation therapy, where a beam of radiation is directed into the body. This may also be called X-ray therapy, 3D conformal radiation, intensity modulated radiation therapy, or IMRT, or proton therapy. Internal radiation is when a source of radioactivity is placed inside the body near the tumor. This is called brachytherapy or implant therapy. External radiation. Treatment can be given once or twice a day depending on the treatment plan. Treatments are often given 5 days a week for many weeks. The number of weeks will depend on the total dose of radiation that is planned. When radiation is used to treat metastases, spread of cancer, it's often given in short courses over just a few days. Patients may be given a break from treatment on the weekend. This gives normal cells some time to heal and can reduce side effects. Patients receiving external radiation are not radioactive or dangerous to the people around him or her. Seeds, or small pieces of radioactive substance, are implanted close to the tumor. This delivers a high dose of radiation to a small area of the body. This can prevent nearby healthy tissue from being harmed. The substances used for internal radiation include radium, cesium, iodine, and phosphorus. The radioactive implants may be placed short-term or can be permanent. The radioactive effects wear off over time. Patients with radiation implants may need to be isolated from family or visitors for a short period of time. This is to protect others from exposure to radiation. Patients receiving internal radiation will be given safety instructions based on their treatment. What are the side effects of radiation therapy? Radiation can damage normal cells as well as cancer cells. The side effects the patient may have will be related to the area of the body that's being treated. The following list includes some of the most common side effects that happen while getting radiation therapy. If side effects become severe, treatment may be put on hold. Treatment may resume when the side effects are managed. Most side effects are short-term, occurring while the patient is on treatment. They tend to go away within a few months after the treatment ends. They can include skin reactions. There may be some reddening of the skin. The area being treated may become irritated, dry, or sensitive. A skin reaction may look like a sunburn. Treat the skin gently to avoid further irritation. Hair loss. Hair loss can happen in the area being treated. Patients will only lose hair as a result of radiation on their head if radiation is directed at the head. In some cases, the hair will not regrow after radiation. Hair that does regrow back is often thinner. Nutritional problems. Radiation can affect the mouth, throat, stomach, and/or bowel when these areas are in the radiation field. This can lead to pain when swallowing, changes in how food tastes, nausea, and diarrhea. Medications can be used to treat nausea and diarrhea. Oral rinses and pain medicine may offer some relief for ulcers of the mouth and throat. Over-the-counter mouthwashes should be avoided, as many contain alcohol, which can sting. Foods that are soft or soothing to the throat, such as ice cream or water ice, may be helpful. Fatigue. Fatigue is one of the most common side effects of radiation therapy. Patients should try to balance normal activity with periods of rest. It can take several months or more after treatment ends for fatigue to resolve. Neutropenia. A neutrophil is a type of white blood cell that fights infection. During radiation treatments, the body's number of neutrophils may be decreased. This is called neutropenia. This puts the patient at a high risk of getting an infection. Patients and those around them should wash their hands often to lower the risk of getting an infection. Avoid people who are sick or have colds, and patients should contact their provider right away if they have a fever, temperatures of greater than 100.4 degrees Fahrenheit, sore throat or cold, or a sore that doesn't heal. So how does it work? The radiation can directly damage the DNA by causing breaks along the strands of genetic material, and it can also trigger the formation of very reactive molecules from water in the tissue that themselves can be damaging. Unable to cope with this assault to their lifeline, ultimately the cancer cells die. Radiation can fracture strands of DNA. Since the radiation has to travel through healthy tissue to reach its targets, non-cancerous cells may too become damaged by the treatment. Cells have their own tools to fix damage to DNA as it arises, but in cancer cells, these are often faulty. So while healthy cells are usually able to stitch their DNA back together and avoid the fatal consequences of radiation, cancer cells can't. That's why radiotherapy is given to patients across a number of sessions that are spread out over time. These gaps allow the healthy cells to recover. Any damage to healthy tissue is a potential risk, though, and can lead to side effects. Reducing this risk is crucial to making the treatment kinder for patients, and why modern radiotherapy techniques aim to minimize this collateral damage while also maximizing the dose that the tumor gets. Over the years, scientists have come up with a number of ways to make radiotherapy more elegant and precise, but in principle, the treatment remains the same: a high dose of radiation aimed at the tumor. Although there are many types, broadly, radiotherapy is given in two ways: from either outside of the body, external radiotherapy, or inside, internal radiotherapy. Not everyone has radiotherapy as part of their treatment, but which one is used depends on the type of tumor and where it is in the body, among other things. For example, a type of internal radiotherapy called radioactive iodine therapy is very effective treatment for patients with thyroid cancer. The radioactive iodine is given as a drink or in a pill and is then taken up by the thyroid cancer cells, but not healthy cells, and hence has few side effects. This is known as radioactive liquid therapy and is one of two main types of internal radiotherapy. The other is called brachytherapy, involving placing a radioactive implant next to the tumor, such as tiny metal pellets or wires. Although internal radiotherapy works well for certain cancers, external radiotherapy is the most common type used. Different types of radiation are used here, usually X-rays, but sometimes tiny particles like protons, which are found in the hearts of atoms. The radiation is hurled toward the tumor in beams ejected from highly sophisticated machines, most commonly one called a linear accelerator, rather than relying on a degree of guesswork like in the very early days of radiotherapy. Today, doctors take a detailed image of the patient's tumor and their surroundings using techniques like CT or MRI scans. This helps doctors plan the treatment very precisely in 3D, so the tumor bears the brunt of the blow while the neighboring healthy tissues are spared as much as possible. There are a variety of other tricks to make the treatment more accurate, such as aiming the beams from a number of angles so that they can closely shape the tumor, or switching up their intensity. Radiotherapy has been around for decades and is often extremely effective, but researchers are still discovering new ways to use it. This includes testing new drugs alongside radiotherapy. The aim is to increase the chance of a cure by making the radiotherapy more effective at killing cancer cells, says Professor Anthony Chalmers, a cancer research UK-funded radiotherapy expert at the University of Glasgow. But avoiding making side effects worse is a challenge. So research is focused on finding drugs that enhance the effects of radiotherapy on cancer cells, while leaving normal cells unaffected. Professor Kevin Harrington, Joint Head of the Division of Radiotherapy and Imaging at the Institute of Cancer Research in London, says the precision of radiotherapy will have a big part to play in this. The more precise we can get the radiation delivery, the better the opportunities we have to combine some of the new smart drugs with radiation, he says. High-tech radiotherapy methods that deliver as little radiation to normal tissues as possible, while maintaining or escalating the dose to the tumor, are ideally suited for these combinations. The studies are underway to test if certain drugs can make radiotherapy more effective, or if radiotherapy can make other drugs yield better results. Radiotherapy causes damage to DNA, both inside cancerous and healthy cells. If cells can't repair this damage, they die. This is good news if the cancer cells are dying, but not if it's a healthy cell that are affected. Crucially, some cancer cells are reliant on certain processes to repair the damage caused by radiotherapy. And it's this knowledge of how cancer cells respond to radiotherapy that researchers are exploiting in combination studies with targeted drugs. The idea is that the radiation and other types of cellular damage triggers DNA damage. The tumor relies on a specific pathway to fix the DNA damage, and you come in with a drug that blocks that pathway, says Harrington. Normal cells have the backup pathways they can use to get around the drug, whereas the tumor is absolutely addicted to this pathway, and you've blocked it with the drug. Different drugs that target key DNA damage response molecules are already being tested with radiotherapy in clinical trials covering a broad range of tumor types. One molecule involved in repairing DNA damage is PARP, and Chalmers is studying how blocking it might make radiotherapy more effective. We've shown that PARP inhibitors increase the effect of radiotherapy on rapidly multiplying tumor cells, but have no impact on non-proliferating cells, he says. This is the case of a type of brain tumor called glioblastoma. It's made up of a rapidly proliferating tumor cell, but the cells of the surrounding normal brain are essentially non-proliferating, Chalmers adds. And they're testing this out in 2 early glioblastoma trials. It's important to work out which patients will benefit from using these drugs alongside radiotherapy. Identifying and measuring molecules that distinguish between normal and cancer cells, called biomarkers, is one way of doing this. As part of these trials, the team will collect tumor and blood samples from patients with the aim of identifying biomarkers to predict who might benefit from the future. PARP inhibitors are clinically furthest along in this journey, but others are being developed that could be more effective in sensitizing tumors to radiotherapy. The early work around all of these treatments will make sure they don't increase side effects. And it's not just how cancer cells repair their DNA that scientists are targeting. The way tumors produce energy, responds to the harsh environment, and spread around the body are all different to normal cells, and so have the potential to be exploited with drugs and radiotherapy combined. But there's another side to the combinatorial chain. This kind of work illustrates the potential of using cutting-edge treatments alongside older, tried and tested techniques. And it's an example of how researchers are trying to be smarter about the tools they have to hand, combining treatments to improve effectiveness and reduce side effects. But some of the usual questions remain. Which treatments will best suit which patients? And will any positive effects be long-lasting? The journey to find the best way to combine drugs and radiotherapy has only just begun. All individuals have an immune system. This system helps protect us from infections and other threats to the health of the body. These threats include viruses, toxins, allergens, and bacteria. In most cases, the immune system is not able to identify cancer as a threat to the body. Cancer arises from cells within the body, whereas viruses, bacteria, allergens, and toxins come from outside of the body. Cancer cells are mutated versions of normal cells. Thus, the immune system doesn't recognize them as threats, and a response is not activated. In addition, some types of cancer can interfere with the immune system's ability to function correctly. Only recently did scientists start to realize the potential of the immune system to fight certain diseases, including some cancers. Immunotherapy is a method of treating cancer that uses the body's own capabilities to identify and kill cancer cells. Immunotherapy might also be called biologic therapy. Immunotherapy treatments may be used to attack cancer cells directly, to stimulate the immune system to respond to the disease, or to prevent a cancer from returning after treatment. Immunotherapy can also work to strengthen or restore the body's natural immune function to make it easier for the immune system to destroy cancer cells and to prevent cancer from spreading to other parts of the body. Use of immunotherapy can actually be traced back to the 1890s when bacteria was injected into a tumor in an attempt to encourage a response of the immune system against the cancer. However, immunotherapy research and available treatment methods had grown greatly in the past 20 years. Types of immunotherapy are currently approved to treat several types of cancer, including leukemia, lymphoma, breast cancer, prostate cancer, lung cancer, bladder cancer, and melanoma. Immunotherapy is being studied in clinical trials for almost all other types of cancer. What are the types of immunotherapy? Just as there are many types of other chemotherapies, there are many different kinds of immunotherapy that act in different ways to kick the immune system into action against cancer. Types of immunotherapy include monoclonal antibodies, laboratory-created antibodies that target a specific antigen or protein. These medications work by targeting something found on the surface of the cancer cell, marking that cell to be destroyed by the immune system. These medications may also work by blocking a receptor found on cells that are important to growth. Cancer vaccines. Like other vaccines we receive, cancer vaccines are comprised of cells that have been modified in the lab to direct an immune response. There are a few different types of cancer vaccines, but primarily they function either to prevent the disease, like the HPV vaccine, or to treat the cancer directly, tumor cell vaccines, antigen vaccines, dendritic cell vaccines, or vector-based vaccines. Cytokine therapies. Cytokines play a very specific role in the immune system. They facilitate communication among different immune cells while also assisting in the launch of an immune response. When cytokine therapy is used to fight cancer, it is focused on using the substances to promote immune system response. Adoptive T cell transfer. This therapy encourages the body's T cells to fight cancer. There are two types of this treatment. The first removes T cells directly from the patient's tumor, produces large quantities of these cells outside of the body, and then reinfuses them back into the patient. The second method also removes T cells from the patient, but the cells are then enhanced in the lab with new receptors called chimeric antigen receptors. These receptors target specific antigens in the patient's cancer cells, stimulating the immune response against the cancer. Donor lymphocyte therapy. DLI involves the infusion of lymphocytes, types of white blood cells, from a donor to a patient who has already had an allogenic bone marrow transplant from the same donor. The donor lymphocytes may assist in identifying targets for immune system attack. This can induce remission or possibly prevent relapse in patients who are at high risk for relapse after bone marrow transplants. DLI can also cause graft versus host defense disease, a potentially serious side effect in which the recipient's cells or tissues are attacked by the donor immune cells. Radioimmunotherapy. This is a combination of monoclonal antibody and a radiation source. This results in radiation being delivered directly to the specific tumor cells, but often in lower doses and over a longer period of time. Virus immunotherapy is a type of therapy that uses viruses to deliberately infect the cancer cells, which then triggers an immune response against the virus and the virus-infected cancer cells. Examples of viruses being used to study this therapy include the poliovirus and the herpes simplex virus. These methods are still being used in clinical trials. Immune checkpoint inhibitors are medications that block tumor cells from activating T cells. This allows the T cell in the immune system to remain active in fighting the tumor. How is immunotherapy given? Immunotherapies may be given into a vein intravenously or by injection either under the skin subcutaneously or in a muscle intramuscularly. Therapies may also be given into a body cavity to treat a specific site. Many immunotherapies are approved by the U.S. Food and Drug Administration, but many more are still being tested in clinical trials. Depending on the type and stage of cancer, some patients may be treated with immunotherapy alone, while others may receive this in conjunction with other therapies like chemotherapy, surgery, or radiation therapy. What are the side effects of immunotherapy? Although many immunotherapies use substances that occur naturally in the body, side effects can occur as a result of the increased production or the higher than normal levels of these substances. The most common side effects are the result of the revving up and stimulation of the immune system. They can include fever, chills, body aches, or flu-like symptoms, nausea and vomiting, loss of appetite, and fatigue. Depending on the doses and how the therapy is administered, patients may experience an allergic type reaction that may cause a decrease in blood pressure, difficulty breathing, rash, or swelling at the injection site. Each therapy may have side effects specific to the cells that are being affected in the therapy. Immunotherapy is relatively new, and we're still learning what the long-term side effects may be in years later. Targeted therapy is a type of cancer treatment. Chemotherapy works by killing cells that divide rapidly, which includes cancer cells, but may also include types of healthy cells like hair, the gastrointestinal tract, blood cells, and other cell types. Targeted therapies work by targeting something specific to a cancer cell, which allows the medication to kill cancer cells while preserving the health of most normal tissues. Sometimes the target is found on a certain type of healthy cell, and side effects occur as a result. Targeted therapy is sometimes called precision medicine or personalized medicine, as one person's cancer may be treated differently than another's based on the targets found on their tumor. Immunotherapy is one type of targeted therapy. Targeted therapy medications work by inhibiting molecular targets in the cancer cell that contribute to its growth, spread, and progression of the cancer. In many cases, the healthcare provider will have to test the tumor to determine if a specific target is present. Even though individuals may have the same type of cancer, they may not have the same molecular targets to target. Thus, the same targeted treatment doesn't work for everyone with the same type of cancer. In addition, just because the cancer target is present, it doesn't mean the tumor will respond to the targeted therapy. Common molecular targets, or mutations, that are treated with targeted therapies include receptors and signaling molecules. The healthcare team may test the patient for these mutations depending on the cancer type and if a mutation is known in that cancer type. Targeted therapies are currently Food and Drug Administration approved for the treatment of many cancers, including breast, colorectal, lung, thyroid, and prostate cancers, lymphoma, leukemia, myeloma, CLL, and melanoma. Targeted therapy may be given alone or in combination with chemotherapy, radiation, and/or surgery. Clinical trials studying other potential targeted therapies are in progress for many other cancer types.